completing my junior year in biology, and I work here as a research assistant at the Rocky Mountain Center.
Okay, so in our research, we aim to assess the relationship between cardiovascular disease risk stratification by the American College of Sports Medicine and carpal tunnel syndrome. Our exposure, cardiovascular disease, is a systemic disease involving the cardiac. $610,000 deaths annually in the U.S. 1 in every 4 deaths can be attributed to cardiovascular disease and is the leading cause of death in both men and women. Work-related impacts from these two include compensation of workers' costs, lost productivity, and disability. So this study was important to Pranjal and I because there hasn't been much research out there between the cardiovascular disease risk and diagnosed carpal tunnel syndrome. So data for this analysis was taken from the Wistaw hand study. It was a prospective cohort study of distal upper extremity musculoskeletal disorders, which was conducted by the Rocky Mountain Center for Occupational and Environmental Health, the Center for Ergonomics at the University of Wisconsin, and the Department of Physical Medicine and Rehabilitation at the Medical College of Wisconsin. So this was a multi-center prospective cohort study that recruited 1,215 industrial workers from a variety of work sites. Inclusion criteria included 18 years of age, employment at one of 17 different production facilities, and a consistent level of daily physical job exposure. Example of some of these facilities include meat processing, automotive engine parts manufacturing, meat processing, apparel manufacturing, and many others. So there was a variety of processes conducted with the participants. Questionnaires administered to the participants included over 266 items. There was also, these questionnaires included everything from complete medical history to physical activity and hobbies to psychosocial factors. Some of the baseline assessments also included blood analyses, structured interviews, and nerve conduction study testings that were conducted by principal investigators and research assistants. So we use the American College of Sport Medicine's coronary artery disease risk factor threshold for risk stratification of participants. This risk stratification is used to categorize people in low, moderate, or high risk for exhibiting cardiovascular disease in their lifetime. So next to me are the kind of thresholds that define positive risk factors. These include family history, cigarette smoking, hypertension, dyslipidemia, impaired fasting glucose, obesity, sedentary lifestyle, and high serum HDL. For our research, we only had available data for cigarette smoking, hypertension, dyslipidemia, impaired fasting glucose, obesity, and sedentary lifestyle. So if a participant had any of these positive risk factors defined by these categories next to me, they were given a point which was totaled for a score ranging between 0 and 6. So low risk category involved males under 45 years, females less than 55 years, with no more than one positive risk factor listed on the slide previously. The moderate risk category included males greater than 45 years and older, females 55 years and older with no more than 2 positive risk factors listed on the previous slide. And then the high risk category included patients with one or more of the following diagnosis or symptoms, including diabetes mellitus types 1 and 2, thyroid disorders, renal disease, or tachycardia. Okay, I gotta give you this.
Thank you. So I'm going to be taking over from this slide. So data was analyzed using statistical analysis system 9.4. We used frequencies, means, logistic regression analysis, univariate model for our exposure factors, multivariate model for confounders, 95% confidence intervals, and odds ratios to carry out the analysis of our data. Confounders we controlled for included strain index, osteoarthritis, job satisfaction, handedness, and mental exhaustion. In our models, we analyzed ACSM risk stratification categories versus each other, and ACSM risk factors total scores versus each other. So here is our demographics table. This is how our population looked like. We had approximately twice as many females versus males in this participating in this study. Around 10% of workers were diagnosed with carpal tunnel syndrome, and of those diagnosed with carpal tunnel syndrome, there were more than 3 times as many females with CTS than males. Of those males and females, those with carpal tunnel syndrome had a higher mean age, higher BMI, which fell into obese BMI range, and a higher total of ACSM score, less total physical activity per week. For example, those with carpal tunnel syndrome exercised approximately 30 minutes per day each week, while those without carpal tunnel syndrome exercised approximately 20 minutes per day in each week. Now, if you look towards the bottom of the demographics table, more than 30% of people with carpal tunnel syndrome appear to have cardiovascular risk factors, including hypertension, dyslipidemia, and thyroid disorders. Yeah, this was our first model of multiple regression of carpal tunnel syndrome and ACSM stratification. For the ACSM risk stratification model, workers in high ACSM risk category are 4 times more likely to have carpal tunnel syndrome than those with low risk category. Workers in moderate risk category were 2 times more likely to have carpal tunnel syndrome than those in low risk category, as you can see. The second model we used was a total ACSM score model. Workers who received an ACSM score of 4 positive risk factors are 3.5 times more likely to have carpal tunnel syndrome than those who received a score of 0. Workers who received an ACSM score of 5 and 6 positive risk factors are 2 times more likely to have carpal tunnel syndrome than those with a score of 0. There were very few participants receiving the score of 5 and 6. As you can see, the total number is only 15. That's why it gave us less significant odds ratio than those with a score of 4. Hence, you can see the inconsistency. Additionally, of those confounders that we controlled for, strain index, osteoarthritis, and family problems were the only factors which showed statistically significant results. Participants who reported often having family problems than those who did not were 4 times more likely to have carpal tunnel syndrome than those who didn't have family problem. Our findings contribute to the growing list of evidences that there is an association between carpal tunnel syndrome and cardiovascular risk factors. Strengths of our study include that we had a larger sample size, so there is a generalizability to many industrial populations. We had actual measurements of cardiovascular risk factors, and carpal tunnel syndrome was diagnosed with a reliable technique of nerve conduction testing, and it was not just a self-reporting, so the data was more reliable. Our findings are a unique addition to the literature because we did not find any study assessing the relationship between ACSM scale and carpal tunnel syndrome during our literature search. Our limitations of the study included that there was we did not have data on 2 of the 8 ACSM positive risk factors, and it was family history and high serum HDL. Again, this was only a cross-sectional study, so we could not assess the causation. Austin and I are planning to write a research paper with our results, and I think further longitudinal studies are required to assess the actual causation. I would like to thank our principal investigator, Dr. Kurt Higman, and my mentor, Matt Thies, colleagues from Rocky Mountain Center, and of course, our sources of funding. And questions? Yes?
You mentioned in the introduction the ethnicity factor. What is that? Was that taken into account?
So yeah, in the introduction, we actually introduced the that was not included in SESM scale that we actually used. It was just a background information. That.
So I'm pretty familiar with the ACSM risk factors, and I was wondering how you decided to use that in relation to carpal tunnel syndrome. So what prompted that method of correlation or comparison or prediction?
I think it had a lot to do with the data set that we had available and the factors that we had available. We looked at the Framingham Heart Study and then ACSM, and I think that based on the data that we had, we felt that we could more, apply it to the data set that we had. And so we also did a background literature search and found that there was very little or to none on it, so we thought that we would go ahead and investigate it ourselves.
I'm not sure if you mentioned this or not, but do you happen to control for the type of job your subjects have? Because I figured maybe some jobs that are more conducive to a sedentary lifestyle would promote
So one of the requirements is having a consistent level of daily work exposure. So I guess I'm not too sure on that one. Just as long as their active life or their active work life was very consistent throughout, that made them applicable to be part of the study.
Yeah, and this has been going since 2001, I guess, and we started working on it right now. So I think Dr. Matt Thies will be able to explain about the population much better than me.
So yeah, we have strain index in there, certainly to occupational measure, but we didn't look at specific job tasks, just because given that there's so much variability in it, that's just one of the things we're going to address.
And if I can add, it may have gone by because it went so fast, but the strain index remains significant in the model. So there are other factors beyond the cardiovascular disease. So we have fully investigated this. We have looked at it with a Framingham
across your cardiovascular risk factor groups, or was there differences in that?
They were actually evenly distributed.
Okay, so are you planning on publishing that data somewhere?
So
What was the distribution? I'm just kind of curious.
So, yeah, if I go back to this demographic slide, yeah, we did have a fair amount of distribution between gender and of those males and females diagnosed with carpal tunnel syndrome, there were, I think, 2 times. Yeah, we had approximately 2 times as many females versus males.
Right,
So,
yeah, that's normal, but I'm wondering how is your distribution, what's your male-female distribution in each of the cardiovascular groups? Like, is there more females, say, in high-risk groups, and does that contribute to a higher risk of carpal tunnel syndrome just because you have more females in your high-risk group?
I don't know. We didn't include that in this presentation. We do have some
Yeah.
statistics behind it. That's definitely something we want to implement in our papers.
Great. Let's thank our. Oh, is there one more question? I'm sorry.
But it was very interesting you said that also relates to stress and the CPS. So did you actually add more psychosocial stress courses at home to see if there was
Yeah, so in this study, we have not considered the rate of stress as a factor, but we do have studies which focused on.
Our prior analyses of job satisfaction have been negative in this area as opposed to the family problems issue, which is rather interesting.
All right. Great. Thank you.